Hello everyone, I am back with some more guides and today we're going to talk about EKGs and how you treat it. So the sinus bradycardia, Brady means it's going to be less than 60 heartbeats per minute, okay? And then you can see here as slow, there is a huge gap in between each beat. It's Brady, it's slow. What can cause that? Hypoperfusion, hypotension, pale, cool skin, weakness, angina, dizziness, syncope, and all these. Now, the most important part to know about this is the treatment, how you treat it. They more often ask about what is this and how you can treat it. So this is a bradycardia, and then how you treat it is you're gonna give O2 and fluids first. Atropine, pacemaker if they need it, and then you're gonna stop any drugs because number one, hypoperfusion and all these happens is because of a drug that you are taking. So if you're taking an IV medication, you need to stop it right away because that's what's causing the bradycardia. So you need to know the cause first. Now, sinus tachycardia. So this one is going to be greater than 100 beats per minute. So if you notice over here, it's all slow and there's a huge gap. Over here, there is not a huge gap and there is more often beats, okay? Beats. So it's more than 100 beats per minute. It's usually P, Q, R, S, T. P, Q, R, S, T, okay? So of this one, manifestations, it could be dizziness, dyspnea, hypertension, all those. But what you really want to do is treatment. You want to remember the treatment, okay? Basically, what happens when you're tachy? What could cause tachycardia? Let's think. The first thing I would think about when you're scared, when something is wrong, someone's hitting you, trauma, like anything could cause tachycardia, right? So you want to basically it's guided by the cause. For example, if you're having an angina, if you're having pain, I'm going to treat that pain. This is going to go down, right? If you're having a low oxygen flow, I give you oxygen, it's going to fix itself. If you're having less fluids, I give you fluids, it's going to fix itself. And anxiety, I'm going to give you anxiolytics, it's going to fix itself, okay? Vagal maneuvers, have the patient cough, sneeze, and bear down. Remember, cough, sneeze, and bear down, okay? Okay, a flutter. Remember, arterial flutter. I call it a flutter. Do you see this right here? It's a sawtooth, right? Sawtooth everywhere. That's how you're gonna recognize it's a flutter. So there's no P wave, okay? Remember the P wave is this, like I said, it starts P, Q, R, S, T. So there is no P wave. It's a sawtooth shaped flutter. You can't really miss it. The arterial rate is going to be 200 to 350 per minute. Arterial, remember, arterial rate is going to be 200 to 350. It's going to increase the risk of stroke because it stays in the atria. The treatment is basically, the goal of treatment is to slow the ventricular rate to less than 100 with calcium channel blockers or beta blockers. Or if this doesn't work, you can do electrical cardioversion, which is the most important step, is not forgetting to push the synchronized button. That was a U word question for the NCLEX, you don't have to worry about that now. And Coumadin to prevent strokes. Now, AFib. Let's talk about AFib. Arterial fibrillation. You see the difference between a flutter is there's a seesaw. Now arterial fibrillation is fib waves, okay? So there's no P wave still, and then the R waves are not regular, okay? So it's basically disorganization of the arterial electrical activity due to multiple ectopic, resulting in loss of effective arterial contractions, right? So The PR is not measurable. The QRS complex is usually normal, has normal shape. Okay, so see, remember, seesaw right here, the arterial fibrillation is not going to have a P wave. So do you see that space over here? Space, 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 no P wave. This could happen, like, you know, increase with age, usually occurs in patients with underlying heart disease. Treatment is ABCD. So ABCD: immunoderon, beta blocker, calcium channel blocker, and digoxin. The treatment goal is to slow the ventricular rate less than 100. The drugs to control the ventricular rate, like I said, immunoderon and all these, you're going to do electrical cardioversion if the meds does not work, right? If the meds does not work, if ABC does not work, then we tend to do that after. Okay, that was AFib. Now let's talk about PVCs, premature ventricular contractions. Okay, so the PVCs, there is a pause. You're going to see a pause. Okay, and this occurs when the heart sneezes due to the early P wave. Okay, so this contraction is coming from ectopic focus on the ventriculars. We know that. It's usually there's a huge depression over here when the PVCs, right? You see this? You see this? There's depression over here in the QRS, and the P is early. Manifestations is basically associated with stimulants, electrolyte imbalances, hypoxia, heart diseases. Most of the patients at the hospital will have PVCs. It's a low priority unless it's 6 PVCs per minute or in a row. Treatment, you correct the cause. You know, stress, sepsis, stimulants, coffee, tea, all these. You're gonna give them immunoderon, lidocaine to slow the heart. Now, ventricular tachycardia. Remember, V, 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 V. That's ventricular tachycardia. Okay? It's basically a run of 3 or more PVCs together. It's called ventricular tachycardia. So if you see these 3 together, ventricular tachycardia. So basically what's going to happen, what causes this is decreased O2, shortness of breathing, heart palpitations, lethargic, chest pain, and all these kind of stuff. You can read over here. Treatment, you're going to always assess the patient's pulse first, because it depends if the patient has a pulse or the patient does not have a pulse. If the patient has a pulse, then you're going to do synchronized cardioversion. If the patient is without a pulse, what are you going to do? CPR, defib, you're going to give epinephrine, you can give every 5 minutes, and you're going to give immunoderon if potassium channel blocker needed. You're gonna know what's causing this first, and then you're gonna treat it with antidiuretic medications. So do you see what I mean? Like, it's gonna be V. With a pulse, it's gonna be synchronized cardioversion. Without a pulse, you're gonna do CPR, defib. You're gonna give epinephrine. Here, so VFib, which is ventricular fibrillation, is going to be chaotic. Just chaos. Chaos, chaos, chaos. Okay, so remember, VFib, you are going to defib. As soon as you see VFib, defib. VFib, defib. VFib is going to be all chaotic. Just chaos, chaos, chaos. Okay? The heart rate is not measurable, the rhythm is irregular, and it's chaotic. So you cannot really miss this in your exam, like you can't. Treatment, CPR, ACLS, defibrillation, and epinephrine and vasopressin. Asystole, I didn't put a picture in there because you should already know what asystole is. It's just a line, flat line. It represents total absence of ventricular electrical activity. The B waves are seen, no QRS. It's just a line with little bumps. That's it. Treatment, you're gonna do immediate CPR, ACLS measures, epinephrine, vasopressin, and first give epi, and then you give atropine after. Defib, Defibrillation is basically for VFib and VTAG with no pulse. Remember, please. I put this in here as a general tips taken for defibrillation. You can look at it. And here is the ICD. I'm not sure if you do need to know about this. I just put it in there just in case. The cardioverter is basically an ICD. You want to make sure the most important about this is you want to report any signs of incision, infection, redness, swelling. You're gonna avoid lifting your arm that has the ISD above your shoulder until approved. Resuming sexual activity has to be decided by your healthcare provider. You want to avoid driving until cleared. You're going to avoid direct blows at the ICD. You're going to avoid large magnets like microwaves, MRIs, and all these kind of stuff. Here's a STEMI versus non-STEMI. A STEMI is when the ST segment is elevated. Okay, that's an MI. STEMI. Okay, it's a serious form of heart attack where the coronary artery is basically completely blocked. Okay, so what happens is basically it opens. You need to open the artery as soon as possible because it's blocked, and the treatment is percutaneous coronary intervention, and then you have the non-STEMI, which is a non-ST segment elevation. Right, so it's a less serious from the heart attack. It's manifested by like chest pain or angina. You're gonna place on medication to protect the heart and reduce the workload of the heart, like beta blockers, nitroglycerin, ACE inhibitors, blood thinners, and all these kind of stuff. I have over here a picture. You can see this is a normal ECG. This is called ST depression. This is called ST elevation. Okay, ST elevation is what is basically STEMI. So this is really important because it's a really serious form of heart attack. Okay, and then I'm just gonna give you some tips and hits from my paper. Okay, and then our last thing is that we have 4 types of AV block. The first degree AV block, you're gonna notice the P to Q is super short and the QR is like spiked up. So you're gonna notice the R is always like primed, like spiked. Okay. The second degree AV block, you're gonna notice that there's like 2 humps, like PP, PP, PP before the QR. So you have the first degree AV block, like I said. You have the second degree AV block type 1, and then you have the second degree AV block type 2. Honestly, I just remembered these by the way they look. They really did not focus on them on nursing school, but they might for you. So just remember how it looks. And then lastly, you have the third degree block. As you can see right here, there's a prolonged between the P and the other P. If you can see, look, we don't have a P here. It's QRST P. Pause. P QRST, and that is the third degree AV block. So remember, you're gonna have a little Q, little R, a little S, and a spike on the R. Okay, R prime. Mostly that is caused by congenital heart defect, MI, PE, hypertension, and myocarditis. If you have any questions, just let me know. I have these papers right here with some EKGs and then the answer in the back. I can send you guys these. Just comment your email in the comments and I'll shoot you an email with them. You guys, good luck.